All right, I think we can get started. Wow, this is loud. Thanks for being here after lunch. We are excited for this session. I'm Anastasia. I'm a senior writer at Fierce Healthcare, and we're going to talk about substance use disorder and serious mental illness today. And I'm going to let everyone introduce themselves. Reminder that we'll be doing Q&A at the end, 5 to 10 minutes. And please use the QR code on the screen. You can scan it, send in your questions. I'll have the iPad ready to go. All right, Cooper.
Hey everyone, I'm Cooper. I'm the president of an organization called Groups Recover Together. We are the largest value-based addiction treatment provider in the country.
Nzinga Harrison, co-founder and chief medical officer at Eleanor Health, where our mission is to help people with addiction live amazing lives.
And I'm Ken Zimmerman. I'm the CEO of Fountain House, which is an innovative approach that says community is a therapeutic intervention, and for people with the most serious mental illnesses, there's a 75-year history of actually enabling people to recover and live their fullest lives by making people, place, and purpose at the center of a voluntary community.
Hey everyone, Darren Webb, the co-founder and CEO at Mindset. We assist those with mental illnesses and their caregivers in applying for Social Security disability benefits, both programs, SSI and SSDI.
Great, thank you all so much. So just to level set for a second, what do we know about how incarceration is linked to substance use disorder or serious mental illness? Anybody can kick us off.
Should we go down the line again? Yeah. So if I can tell a very quick story. My first introduction to this, I sat down with the warden of the largest prison in the state of Maine, in a town called Warren in 2017, and I said, what % of your residents do you think struggle with substance use disorder? Expecting the answer to be 10 or 20%. And he said, everyone, like everyone. And there's this whole, obviously I think everyone knows about the trend of deinstitutionalization in the 70s and how like the burden of caring for folks with SUD and SMI has been shifted to corrections, which is bad and problematic and expensive. But what we learned is that this is a massive, massive, massive problem in the justice system. And the thing that we've spent the last 7 years doing since then is figuring out how to change the trajectory for folks who engage and drive really great outcomes, which I'm sure we'll talk about in a bit.
Yeah, I think the relationship between substance use disorders and incarceration is bidirectional. So 70 to 80% of people in a setting of incarceration will have a substance use disorder. These systems are inadequately designed and inadequately funded to address those needs while people are there. The trauma of incarceration then increases the risk of return to use upon discharge, and we know for individuals with opioid use disorder, the absolute most deadly time, highest risk for overdose, is the month after release. And so just very personally, one of my best childhood friends, her brother was my brother's best friend, she was my best friend. Troy McQueen is his name. She'll appreciate me saying his name. Struggled with substance use disorder, was in jail for 4 months, celebrated for not using in jail, which you absolutely can. There's a significant drug availability in jail. Came out of jail with no insurance and no connection, and was dead from overdose 3 weeks later at the young age of mid-40s. And so the relationship is inextricable.
I mean, just to double click on both of this, I think it's really important to remember that the failures in the behavioral health system and the failures in the criminal justice system intersect. And it's a sad reality. The largest institutions that serve people with serious mental illness and substance use are the jails in New York, Chicago, and Los Angeles. I've been for many years on a commission to try to close Rikers, the jail in New York City. And what's striking at this point in time is that not only do 56% of those still there have a serious mental illness, but in many respects, the issues are now the same. The issues of criminal justice and serious mental illness and substance use are the same. And the waste, not only in human lives, but in cost, but in the failure of other systems to actually be able to function are huge. So the only thing I'd add, we talk about criminal justice, and I just want to extend it to who ends up in the criminal justice system, because I think, as Cooper said, unfortunately, what we've done is we've put police in a position where they're asked to take on a whole lot of things they are not equipped to do, and as a result, the entry into the criminal justice system includes a lot of people with substance use disorder and serious mental illness who should never be there. As Nsinga said, the conditions are exacerbated by what happens, and then we fail to provide what we know is needed, whether it's housing, whether it's social supports, supports to family, benefits, when people come out. And those linkages are why it is absolutely connected throughout.
That's right. And you said it correctly. Correctional facilities are modern-day mental health facilities. We partner with inmates before they're released, about 3 months before they get out, to collect their information. And one thing that we're seeing is 15% of our claimants that we get and we reach behind the wall, it's the first time that they've had severe depression symptoms, being behind the wall and seeing how that's affecting them. There's in many facilities we're partnered with, there's one social worker for every 450 inmates. There's one case manager for every 450 inmates. Maybe there's a doctor that works there. They're understaffed, under-resourced, and I've yet to have a claimant who was treating outside of the wall become incarcerated and come out saying that they're better. Yeah. On the flip side of that, this is a personal connection for me. I have a loved one who suffers from schizophrenia. And when he became incarcerated, actually, I felt better because I knew that he would get the medication that he needs. So that's something that we need to figure out, and everybody here is working on great solutions to make that happen.
Yeah, you just kind of touched on it, but I'd love to hear from others, from your perspective, what the barriers to mental health treatment are in correctional facilities and jails and prisons around the country, and if you want to add what populations are specifically at risk. I'm thinking of pregnant women, other folks.
Yeah, we can go down the line again. So I think that one of the primary barriers is the providers of correctional health care have disincentives to do good work, right? Like, so let's set aside, we've talked a little bit about the structural stuff. Let's set aside that. Once you are there, these organizations that provide health care, including mental and behavioral health care within correction systems, are contracted, typically. They are for-profit, privately owned companies, typically. They are paid a cap rate, so they're paid one amount for all of the services they render in a given year, and everything they do cuts into their margins. That's problem one. Problem two, kind of horrifically, the majority of escapes from prisons and jails happen in hospitals. So I think what those folks would say is we're actually doing a really good job in an impossible situation. And when all of that is taken together, it's nearly impossible to get high-quality care. Now, there are any number of other issues. We, as a society, don't give a shit about these people, which, pardon my language, which is a huge problem, and we don't put the resources we need to, which is insane, right? Like, if you think about what we do, right, the money that we charge to take really, really good care of someone for a year is 1/5 of what the states pay on average to incarcerate folks. The average state pays almost $70,000 a year to incarcerate someone. I think either of our organizations could do an amazing, amazing job taking care of someone for a fraction of that. So those are the barriers. High-risk individuals and populations are especially vulnerable. But it's a real problem, and there are a number of structural challenges to it. I don't know.
Yeah, I think that's exactly fair. I think it's also important to recognize that the barriers for jails are different for the barriers for prisons. So jails are typically a shorter term stay. Their funding is very different. There's no real standardization. So a county jail is different from a city jail, it's different from a state jail, it's very different from a state prison, it's very different from a federal prison. I think systems are disincentivized. I agree with that for sure with for-profit incarceration companies, but I think also jails their primary goal is not health. And so even when you speak to the individuals who are on a medical team in a prison, health is always trumped by security in a prison setting. And also, so my brother, to say this is personal, has been in prison for 30 years. And after experiencing a night of extraordinary trauma. He found himself in this situation. For 30 years, he has never had any mental health care because it's not in the interest of a system that has one person for 450 to identify your needs and then not be able to address those needs. So I think that our prisons and jails are so diverse is the word that I'll use, lack of standardization. The funding is inadequate. They are not trauma-informed. Health is not their North Star. The for-profit interest definitely bastardizes incentives. Then it's this masterful mix of not getting what we want for people, which is health. And health, I really loved what you said, is not just the absence of symptoms. I'm a doctor, so like we're super guilty of this. Health is not the absence of symptoms. Health is the presence of community and life and meaning and purpose. And to your comments, prison could be, or jail could be a place where community starts, but this is just not the purpose that they've been formed for. They've been formed to keep people out of community. That will always inherently make people sick.
I mean, double clicking again. So, but there are two things. I just want to emphasize the scale of what we're talking about. There are 2.3 million Americans who are currently incarcerated in jail and prisons. That's 20% of the globe's incarcerated population is in the United States. 600,000 are released every year. So just as a matter of good social policy, we spend $7.7 billion in correctional health. So it's an enormous thing that we're investing in, and as you can hear, not investing well. So that's part of the case that I think we need to make. But to take it, one step into what the barriers are, part of it is, I think, as was said very well, we view being incarcerated as a state that's entirely distinct from how people live their lives. Think of it, none of us, we may go away for a period of time, we may be hospitalized for a period of time. What happens when that occurs? You emphasize how people are going to resume their lives as what's pivotal to ensuring continued health. Does that happen in the jail and prison system? Not at all. And as a result, at Fountain House, we have 2,000 members, people with serious mental illness in New York. We've been replicated 200 times around the country, just invited into LA right now. But 25% of our members, and that's how we refer to our people, have a history of justice involvement. And we have a fraction of the recidivism that is expected because what we're focused on is community. It's focused, as was said, not only on the biomedical things, that has its place, but because jails and prisons, when people leave, don't focus or frankly are concerned about everything else that makes a difference to us, the statistic about when people are most at risk. To reinforce it just as a policy matter, one of the sort of unacknowledged pieces, even though Darren knows it well, of the ACA, was it extended Medicaid to childless adults. So for the first time, people who were incarcerated, especially single people, were entitled to Medicaid, except if they were in jail and prison. The inmate exclusion does not allow that, but what we're seeing from a policy perspective for the first time is you can now submit a waiver that allows you to start getting Medicaid while you're still incarcerated so you can get that continuity of services. So it's just a very concrete example of the way in which we've siloed the ability to get benefits, prescription drugs, and everything else at the time you most need it.
I think we can talk about this question for the entire time. Just a few thoughts that I've had. I spoke to a high-ranking DOC official, Department of Corrections official. I won't say what state it was. And it comes down to incentives. I let them know that we get inmates when they come out, we get them money, we get them on Medicaid, we get them on food stamps. And he said, you're going to make us lose our jobs. Verbatim, he told that to me. And that's just a horrible thing to say. If we're going to lean in on prisons and hospitals prisons and jails being modern-day mental health hospitals, we need to lean in on building more. There's currently a 3-month wait for an inmate to be transferred to a state-based mental hospital to see if they're competent or not. That's nationwide. That is a massive problem. Even when it comes down to the inmate level and trying to get in touch with them and help them, those that suffer from mental illnesses, they're picked on, they're preyed on. And, you know, we've had trouble with that, communicating with them and getting them to stay in touch with us while they're incarcerated. So I don't know how you fix that, but or any of those issues, but those are three that I've seen, especially along the policy line.
For sure, I think, sorry, I'll just jump in here and then, I think it is similar to value-based care. So I'll just point out all the empty seats we have in here, which comes back to Cooper's comment that we don't give a shit. I was gonna say we don't value the lives of, but we don't give a shit like feels more emotionally appropriate about people who are incarcerated, and we have to start giving a shit. I think if this were value-based care talk, this room would be full, right? And what we know about value-based care is that you have to give healthcare providers longitudinal responsibility for the health of the people they're serving. And so if we take that same thought for jails and prisons, if jails were incentivized for people not coming back, then you wouldn't hear that comment, you're gonna make us lose our jobs, but they're incentivized for full jail cells and full prison cells, the same way a not value-based care health company is incentivized to volume rather than quality.
I mean, Obamacare had a hospital readmission penalty, right? Think about what would happen if we actually had a readmission policy for jails and prisons.
I know. They would be like, how do we
Thought
keep this
experiment,
person
folks.
from
Okay,
coming
let's
back?
just
Yeah.
imagine a future that may look very different than the one we currently have.
Wait, you have a question? Well, I was gonna. Okay. Can we?
She's like
sorry.
the panel.
The panel that's out of control. That's
So I want to talk about. I would like to transition us, if I can. I may be stealing your thunder, to like something slightly more hopeful, which is I would like to talk about something that we're up to, and then maybe we can talk about all of the things we're doing to solve or attempt to make a dent in this problem, because I think it is something that we can do something about, and we have some things. So if I can share a couple of stats. So as an outpatient provider that's rural focused and Medicaid focused, we have the ability to go and engage with Department of Corrections. To your point, it's actually much easier with prisons and jails, given length of stay, and given that jails are typically run by like totally wacko elected officials, as opposed to like people who are appointed. That's neither here nor there. So we've built this program over the last like almost decade, where we go into prisons and we provide a couple of things. A full needs assessment. What are the things you need? Mental health, behavioral health, SUD, housing, employment, transportation, technology. 2, when are you releasing? And then 3, when folks release, we do a couple of things. We give people free cell phones. No one reimburses us for it. There's no way to get paid back. We just do it. We give people free transportation. No one reimburses us for it. You don't get your money back. We just do it. And we give people rapid access to high quality care. So once you get out, the same day you get into treatment. To your point about fatal overdose upon release, you got to move fast or it's too late. And what we've been able to demonstrate in 2 different states is cutting 1-year return to custody rates in half. So in the state of Maine, the average rate of return is 6%, which is actually really low for everyone 1 year. If you have a substance use disorder, it's 10%, surprise, surprise. If you engage with our program, even if you don't get treatment with us, because we send people to treatment with other people, it goes to 4%. So we're really proud of that. In the state of Indiana, where we just started doing this, it's 30% on average. Of everyone who walks out of those doors, 30% of people are back in a year. And if you engage with us, it's 18. So like, it's not good enough. It's not perfect. It still sucks. And like all of these barriers are here. But I think like we're doing this thing that we're really proud of with all of these other community partners, and it's like starting to make a difference a little and feel good. And that's a hopeful thing. I don't know if that's helpful.
We're talking about what we're doing?
I don't know.
Yeah,
I'm sorry. I totally, I apologize.
The panel has clearly
No, that was
gone
literally
rogue.
going to
I
be my
love
next
it.
question, so you're good.
I mean, if we're
Let's do it.
to talk about Fountain House for a second. So we're not exclusively a program for returning citizens. Nonetheless, it's part of why it's so significant not to differentiate, I think, by population. 25% of our members are returning citizens, and yet what's striking is many of their challenges and their opportunities are the same as other people with substance use disorder or serious mental illness. So this model, which is all based on the idea of people, place, and purpose, it's what we all need. And it's absolutely true as a matter of science. The symptomology of people with serious mental illness, when they don't have that, become far more acute. So how do we, no matter, I mean, our own model, focuses on a community that's jointly led by the people with serious mental illness. We have the former head of NIMH and people with serious mental illness on our board. But that idea of creating agency for people to help design what and how they're going to live their fullest lives, some people with capacities that are very high, others perhaps not so much, is actually a missing ingredient in so many of the things, and especially for people coming out of jails and prisons, ends up diminishing their own capacity to fully realize what they're capable of. And so I just noted, I mean, we're proud of what we do. We actually have a 21% reduction in Medicaid rate, quite an employment rate compared to people with serious mental illness, much else very good on education and other metrics. But the real piece is the insight that community is a therapeutic intervention and deserves the same level of resourcing and attention that pharmacology does, that talk therapy does, that the other forms of treatment, as opposed to viewing several of those as the ones that are worthy of being resourced and the others as not being worthy because they're of equal importance in terms of somebody's life trajectory.
I would argue community is of more importance and deserves more resources. He didn't pay me. He didn't pay me.
Yeah, so, we utilize jails as a distribution channel to reach inmates that need to file for benefits, whether they filed before in the past or not. We partner with homeless shelters. We partner with great companies like Groups to help their members get on disability benefits as well. We partner with Medicaid insurance companies to help their members get on benefits. What we've done is we've essentially TurboTaxed that process. With, by yourself, if you do it, it can take you days to weeks. You have to go request medical records. Social Security is going to mandate that you fax them paperwork.
In 2024.
They just closed the Staples by my house. I have no clue where to go find a fax machine. I don't know if anybody else does. And we take care and handle all of that for them for free. We only get compensated if the claim on the back end is accepted by the government, which right now, on average, is taking about 15 months. I'm just very excited to say that for all initial applications, it takes about 8 months to come to a decision. Whether you are accepted or denied at the initial application, 90% are rejected. Our latest cohort from about 9 months ago, we are now seeing a very high level of those initial applications being accepted because the application is full from the beginning, it's fraud-free, medical records are there from the beginning, and we do this all for free. We understand the constituency that we're dealing with. Those with an SMI, they just want to talk to us. They're going to call us. They don't even care about talking about their application. We understand that they're going through a lot of things. Those are, many of them don't have permanent housing, and although we're here to assist them with the disability application, we understand that we have to do so much more to, help them feel okay as they're going through this tough process.
Yeah. So in terms of what we do at Eleanor Health, I started out with our mission is to help people with addiction live amazing lives. Our mission is not to give people access to treatment. Our mission is not to help people get sober. Our mission is to help people with addiction live amazing lives. And so that has to start with understanding what their definition of amazing is and what the barriers in their life to that amazing is. It also understands that just because you have a substance use disorder, that's not the only thing that matters about you as a human. And that is not necessarily, from your perspective, the one thing that you need to fix for everything to be great in your life. So we take care of all substance use disorders at every stage of the illness, including active use, early remission, sustained remission. We drop into secondary prevention we serve people during periods of relapse. We take care of every co-occurring mental health condition that person has. We proactively coordinate for physical health care conditions with coordination and care management. And we have peer coaches and proactively address social drivers of health. None of that matters. I think what matters first is that our model is based in compassion and seeing people and their humanity even during their most vulnerable times. And we call our core 4 equity. Everybody has an equal right to health care. How do we join your team to help you realize that right? Harm reduction, which is a social justice movement that goes way beyond Narcan and clean syringes. It is respecting the autonomy and agency of the people that we're serving. We're on your team. We are not the coach. We are not the quarterback. We are your offensive line and your defensive line. My fantasy team is currently first in the league. Third, trauma-informed care. Trauma is a universal experience. Trauma in the healthcare system for people with substance use disorders and serious mental illness is shocking. And then last is teamwork. We're on your team. And so I really think it's that humanity, compassion, longitudinal relationship, community connection first. We wrap all of those services, which matter, but those can only matter in that perspective, in that context. Reimbursed and value-based care arrangements. Okay, go ahead.
Yeah. One thing, just because I so strongly agree with all that. Like, the way we think about our work is you have to help people find, achieve, and then maintain a life worth being in recovery for, right? Like, and if you can't solve that or help someone solve that, just saying like stop getting high doesn't make any sense. It like makes no sense at all, right? It's like if you're sitting around on your couch getting high versus sitting around on your couch not getting high, like you can't understand addiction as a problem until you understand it as a solution. And I think where the place where we see eye to eye and our organization see eye to eye in maybe an industry that doesn't, generally speaking, is like this is about actually helping folks with life that matters, right? And however you define that, if that's employment, if that's family, if that's resolution of legal issues, if that's stable housing, like it's obviously all those things. But like that's what this has to be about. And I think that to bring it back to our subject here, like if you can successfully support people doing that, you are much more likely to help people not return to custody, right? Like that's how you actually solve that problem, because otherwise you can't solve that problem. Anyway.
Yeah. What role does telehealth play in making these connections and facilitating care and social services delivery?
What role does what play?
Telehealth.
Want to go first?
We're not really telehealth. You want it or you want?
We're not a telehealth, but I will say that I think there are opportunities that virtual provides and telehealth as well. I think for us, it's a complicated dance because on some level, the ability to form connection, which is so critical, I think ends up when those who are doing it well do it very well, but frequently it can be a shortcut to not doing it. So I just want to inject a caution in assuming that telehealth or virtual programming is always it's only upside when it comes to expanding access, even though we desperately need to do it, especially for rural and other populations that have trouble getting support.
So we before COVID were 100% in person. We never did telehealth at all, except for in like weird emergency situations like snowstorms, which happened a fair amount. During COVID, we became exclusively virtual, and today we're hybrid. I agree. Look, I don't think anyone would sit in here and say they'd rather be on a Zoom meeting than sitting face-to-face with someone. At the same time, in the work that we do, telehealth allows rapid access. It allows overcoming geographic barriers. It saves lives. And our outcomes data would tell you that the clinical outcomes associated with telehealth versus in-person care are actually equivalent. So retention in treatment at 1, 3, 6, 12, 18 months, weekly engagement with group therapy and medical appointments, and abstinence. So we actually, like, the data says it's equivalent. I'm not so sure. But the one, again, to link it to this panel, the one piece of data I would offer is in our first implementation of our what we call Safe Start pathway for justice-involved folks, we had to do, this was pre-COVID, everyone went behind the wall. And we still do that today, and we pay $400,000 a year in insurance because if you want to serve justice-involved folks, you have to carry a massive amount of insurance because these are people who are perceived to be litigious, rightly or wrongly. And that's a huge barrier, right? Like we just spend a huge amount of money in insurance companies and if you talk to the insurance companies to try and get this down, which I have, they say horrific things about this population. So by contrast, in Indiana, we don't have to send people behind the walls because we gave everyone tablets. And we are seeing equivalent outcomes, and we don't have to spend $400,000 a year in insurance. So I don't know if that's like, I don't know, that's what I got. That wasn't. It was such a good point, and then I landed the plane so badly.
It was like, we're going to have a little turbulence on landing.
It was so
great.
close.
No, it was great. It was great. +1. So I think access is a huge benefit of telehealth. For people with substance use disorders, which is such a stigmatized condition, I think it offers some privacy. It offers some flexibility that we don't believe people with substance use disorders deserve in the same way the rest of us deserve. We think they need to commit their entire lives to treatment and treatment alone, but guess what? They're doing other stuff too. I think it is important, though. I appreciate your cautionary tale. So likewise, we were 90% in person, 10% virtual, really just leveraging it for medical resources before COVID. Slid to 100% virtual after COVID, have slid back to a hybrid model now. We serve people in the clinic, we do community-based, we do virtual. And the premise of all of our care is from your perspective. And so I think, yes, virtual care can be as effective if it matches that person's preferences. And so that's what I think is the most important part. Telehealth for rapid access. We're always going to be able to get to you faster on camera. But that people have the option to sometimes see their therapist hybrid, virtual, sometimes in the clinic, see their doc, sometimes in the clinic, sometimes see their peers, sometimes in the community, sometimes in the clinic, sometimes on camera. And you can titrate that to the person's preferences. That's what drives our retention rates, and our ability to keep that relationship is what drives outcomes. So there will never be one thing that's right for everybody. This is the lure of healthcare, that we're all looking for the one thing that's going to be right for everybody. It does not exist. And so how do we build symptoms that are versatile enough to meet the individual preferences of a person, but that have the technology and data behind them to be able to scale to meet a lot of people? I think that's the challenge.
And one more thing that I thought of when you're saying this. When we do telehealth care, we don't do anything across state lines, even though you can. And we don't even do anything across states. So we match folks who are getting treatment with providers who are local to their communities. I think that sometimes telehealth, people lose the thread and say, oh, like, it's great, you can warehouse all these clinicians in Utah and get them all licensed in 50 states. But like, someone with a Utah accent is not useful for serving someone who's from Virginia. And we all believe in the power of community and therapy and personal connections and like culturally sensitive and competent care. Like, you actually have to deliver that even in a telehealth environment, or you can destroy your outcomes, I think.
Agree totally with the cultural sensitivity. Disagree that someone with a Utah accent is useless to someone.
Okay, that was, I sort of oversold it a little, but
the connection is what matters. I'm totally with you.
Yes.
The connection is what matters.
And I do think, just to reiterate, that I have nothing to say about the Utah accent, just for the record. But, it's interesting because, like them, we were, for 70 plus years, always in person, have a physical site. And COVID meant that we had to shut down for the first time and ended up entirely on virtual and now back at hybrid. And what's been striking is that about our weekly surveys indicate close to 30% of our members participate at least sometimes virtually. And as we've dug into the data, what's interesting, sometimes it's because people are busy, they've got jobs, they've got employment. Sometimes people, especially for people with serious mental illness, and I should say we're entirely agnostic about whether you have a substance use disorder co-occurring or not, but sometimes people have social anxieties. Sometimes transportation gets in the way. And so, exactly as you said, the key is to make the person the center so that they're making a choice, but to also be attentive that for many of our members, social anxiety has actually been the source of the symptom that's most compromised their ability to move forward. And so it's always a key of being deeply sensitive to why and ensuring that what they want is actually what's being furthered by the method by which they participate.
I love that.
I will say that telehealth has actually helped us a ton for our claimants. If Social Security sees that a claimant is not treating, they're going to get denied. And that's either monthly, at least quarterly. When you apply for SSI, it's asset income based. You can't have more than $2,000 in assets, and you can't make more than $1,500 a month. 80% of our claimants don't have a car. So what does that mean? They can't drive to go see their doctor. They can't drive to see their therapist. So we have partnered with different telehealth companies in different states to allow them to take this call from their phone, from their car, from their home, and we have seen that increase access. And what that does is just democratize access for those that need it.
Really interesting points. Just a quick reminder to our audience that we are taking questions, so if you want to scan the QR code on the screen, feel free to do that, or if that's not working, you can line up at the mic. Wanted to talk about medications for opioid use disorder really quick and what access looks like, and if anyone wants to talk about the MODA Act, we can do that.
You want to start with that, or you want to? So there are three medications, broadly three classes of medications for opioid use disorder. There's methadone, then there's buprenorphine, and then there's sort of the Vivitrol naltrexone full blocker part of the universe. We do two of the three. So we do buprenorphine, we do Vivitrol naltrexone. We are not in the methadone business. I'm probably not going to go down the. Or can we do the methadone thing? Or are we not doing the methadone thing?
Do the methadone.
Okay, so methadone. All right. So here's the thing. There have been like 3 opioid epidemics in American history, right? The first one, which was when heroin and things like that were legal, 1890s, 1900s, 1910s, 20s. Then there was the FDA, and they stopped that. Then the second one, soldiers coming back from Vietnam, 70s, and methadone. Fun fact about methadone was invented by. Does anyone know who invented methadone? Do you know about this? The Nazis. So the Nazis invented methadone because they were worried about losing access to natural opium. And methadone clinics, which to be clear, methadone's like a really important modality that saves a lot of lives and a lot of people matter, but they were deployed in cities as like, it's called liquid bars for a reason, as like a justice involved sort of like we are going to, is bad, is really bad. And it was in that opiate epidemic disproportionately affected black people and people who were living in cities, and methadone clinics were deployed in that way, and also because of the daily dosing requirements, they actually only work in areas of high population density. So when this third opioid epidemic came, which was much more rural, methadone clinics were ineffective, right? You can't deploy a methadone clinic in a very rural community. It doesn't make sense. People have to drive too much. Anyway, point being, there are a lot of medications. Access remains a problem. Access is unequally distributed. But I would argue we're shifting from like a crisis of access to a crisis of quality. And I think where we are today, we've actually made amazing strides in access in all 3 classes of medications. And what we haven't done necessarily is agree as a society on what good looks like, or what outcomes should be, or how we publish that. You're hearing from us, and we feel really strongly about this, and we deliver great outcomes. We are not representative of the industry, and we're not representative of where most people get treatment, period, full stop. Like most people who need treatment are never going to engage with either of our organizations. They're going to engage with whatever happens to be there. And whatever happens to be there isn't very good. And the way we make it better, I think, is by agreeing on national standards and holding ourselves accountable and the payers compensating for that and so on. So that was like 3 different soapboxes. I apologize. Sorry for bringing the Nazis into it.
Can I just add, or were you going to?
No, please.
You don't want that?
I'm not,
We'll probably follow on
but the issue, I think the issue of what we're measuring is a really important one. And I just, jumping off it, because part of what we're doing now, because we believe if community is a therapeutic intervention, we should be held accountable for the results, but the results we should be held accountable for are those that matter. And so we have a Measures That Matter initiative that's using validated survey instruments to measure loneliness, isolation, and thriving, and to say, absolutely, hold us accountable, but hold us accountable on when if you ask people themselves what matters to them. And so whether we think about it as a value-based payment system, whether we think about it as public funding, we've got New York City starting to use it for the first time. It's just part of the way when you talk about the barriers that exist, it's the failure to actually incent the kind of outcomes that we think matter the most. And I would just add that into the conversation because it's relevant both for the modalities that one may apply. It's particularly true for people, co-occurring disorders, always a weird phrase for me. But another huge barrier is the siloing of substance use disorder and mental health, which suggests that people somehow have to choose what they need treatment for as opposed to what we know to be the case, which is 40% of all people have co-occurring, at least. Okay.
Yeah, you're taking me to church.
Which for a Jewish guy is pretty good.
Okay, you're taking me to temple. You're taking me to temple. I'm here with you. I'm here with you. I really want to harp on the importance of patient-reported outcomes measures. They're completely devalued, like we're incentivizing HEDIS. We're incentivizing all sorts of things. I said our mission is to help people live amazing lives. How do you know it's amazing if you don't prioritize them telling you how you feel? So we scale everything so that we can quantify our outcomes. Social drivers of health. Anyone want to guess number one across all lines of business, across all geographies? Number one member, we call the people we take care of community members because we believe that health starts with community. Number one, anybody want to guess? Across all lines of business, number one social drivers of health need? Companionship. Companionship. Do we get paid to address companionship in healthcare? When we're talking about reentering citizens, which by the way, language is so incredibly important, and you taught me this phrase, thank you, I love it. We think about reentering citizens, citizens returning to our communities. Are we being held accountable to companionship? It is the number one. I don't care if your drug screen goes to 0. I don't care if your depression score goes to 0. I don't care if your anxiety score goes to 0. I don't care if you had an appointment within 7 days of getting discharged from the hospital, HEDIS. Or if you had 2 appointments after your diagnosis in the first 34 days of care, HEDIS, right? Companionship. And so until we start incentivizing and holding ourselves accountable to those things, we're not going to get the health outcomes. You asked about MODA. MODA is methadone. Methadone can only be prescribed in methadone clinics. We also do not prescribe methadone because the legal and regulatory barriers are too onerous to do it. Methadone is a fantastic medication that is based entirely in stigma against people with substance use disorders. I'm board certified psychiatry addiction medicine doctor taking care of people with addiction for 20 years. I can write a prescription right now for methadone as long as the diagnosis is pain disorder. And I can send you to CVS and you can pick up that prescription. But if the diagnosis is opioid use disorder, then it just sucks to be you if methadone is the medication that is right for you. So MODA is aiming to make methadone available to be dispensed by pharmacies for people with opioid use disorder. It's incredibly important. It will make a huge difference for our returning citizens for whom methadone could be a good medication. We're going to temple together. I see you back there.
Not seeing any questions from the audience, so we have a couple of more minutes. Okay. Just kidding.
Hey there, thank you. My name's Rachel Strife. I'm with Arizona Mad Moms. On October 8th, a whistleblower from Rikers, Justina Zawinski, exposed the practice of deadlocking, which is when you take a seriously mentally ill person and put them in solitary confinement for weeks, months, and not treat them. And this happened to my best friend Crystal's son, Josh, and he died last year. This, to me, is the biggest rights violation of our time. We closed asylums, and now we are allowing state-sanctioned torture of the seriously mentally ill. Where's the outrage? Why is this the lowest attended session that I've been to this whole conference? Our sickest patients are in our jails and prison system. How do we fix this? I know in Arizona we're going to pass a law, hopefully next session, called Joshua's Law, named after Crystal's son, that's going to require jails and prisons to treat persistent and acute disability like schizophrenia. But what are we doing? Nationally, what? Where's the outrage? That's my question.
Thank you. And, I'm doing this work because our oldest child developed a serious mental illness that led to his death a little over 8 years ago. And I say that just because it is the unimaginable. And just want to acknowledge your loss. And I also want to thank you for raising it. I want to thank everybody for attending, because it's a larger question for deeply stigmatized, marginalized people who are disproportionately people of color in this country to not get the attention that they need. What I hope emerges from this, while we have a larger conversation about the outrage, is that while there should be outrage, but there are also solutions that you're hearing about to address these things that are also not being heard. And especially at a time in our national dialogue where, you know, there are these conversations about locking more people up and all the rest. I think it's particularly important to see the ways in which there are real things that can be done, and there are abuses like what you described, which is absolutely real, that should never happen in the country like this one. So I don't pretend to have an easy answer, except all of us, by acknowledging that there's real things that can be done that make sense, they save money, they improve other systems, they make a difference in people's lives, and they save lives, should be a starting point that this conference and other places prioritize. So just want to say thank you and acknowledge it.
Yeah, I agree, thank you. I think, unfortunately, where is the outrage is that it is a persistent human strategy that's ineffective to hide the things we don't know what to do about. And so because this is hidden behind the wall and we think it's somebody else, then that allows us to protect ourselves from the horror of it. And so in terms of what can do, you standing up at that mic, everybody felt it. You being here telling us about your son Joshua, we all felt it. And when we can no longer hide outside the wall and be protected from the horror of that. My brother does not have serious persistent mental illness. He was charged with a bogus infraction in the prison and put in solitary confinement for 3 straight years. 3 straight years. And he heard the guys on the cells on the other side of him going crazy. He has like a fantastic meditation practice. He can meditate like 18 hours a day or something superhuman, which is the only reason he stayed intact, right? But like, this is unfortunately not the exception. This is the rule for what's happening. My father was in jail. He went on a hunger strike. They put him in the suicide cell, which was in the basement with an inch of water that smelled like urine, and nobody came and checked on him. So had he really had suicidality, like, is that the condition? That's not the condition. This is the rule. To develop the outrage, you mentioned the first, second, and third waves of the opioid epidemic. There's no first, second, and third waves. The opioid epidemic has always been here. We were able to develop a collective outrage when it hit the media in a way that showed everybody this is somebody you love. Could no longer pretend it's them, could no longer be blind to it. And so I'm so grateful to journalists. I'm so grateful to people like you that stand up at the mic. I'm so grateful to you for people that advocate with your own personal story, because as we connect to that pain as humans, you cannot continue to ignore it. The outrage develops. We move to investment in opioid use disorders, to compassion, to panels like this. One day this room will be full.
Thank you so much. Thanks to our audience and our wonderful panelists.